Hi, everybody. It's Andrew Gums. This is episode 79 of our podcast, Artificial Intelligence and Cybersurgery. This is the official podcast for our journal, Artificial Intelligence Surgery, the first and maybe only journal dedicated exclusively to artificial intelligence and surgery. I'm here with my co-host, Dr. Vincent Grasso, who will introduce our next guest.
Super, yeah, and welcome, Alice. I know it's Saturday, and thank you for taking time out for joining us. We have a very special guest on our 79th episode, as Andrew said, Alice Tsai. She's a abdominal surgeon who focuses on the esophagogastric region. She's going to talk about what she does at Imperial College Healthcare and the NHS Trust in London area. So we're welcome to our podcast, and please tell our audience about you and your work and what you're doing in AI, perhaps.
Sure. So thank you very much. It's such an honor to be invited to the podcast. And it's a really funny how I'm now on this side of the chair being interviewed. So I am one of the upper GI surgeons in general surgery at Imperial College. And we just touched on about which organs I operate on as being a general surgeon in England in this side of the world. Unlike many other countries in US or maybe in Asia, the esophageal cancers are operated by general surgeons in the UK. So I focus particularly on esophageal and gastric diseases.
So that's already something I want to talk about. So I did my training in the United States, where I'm quote unquote a general surgeon. But now that I moved to France, I am a visceral surgeon, and it always bugged me that I was a general surgeon. Like it sounds like we don't have a specialty. And so I love being a visceral surgeon or a digestive surgeon. I know it's a stupid thing, but is there any of that in the UK? And the reason I'm asking is because I think in the United States, general surgeons don't get the love from insurance companies. You know what I'm talking about, because they're turned general surgeons. Like people have the illusion that they're not special, they don't have a specialty, if you will. So does that also exist in the UK?
No, and I think this essentially, Andrew, if we open this can of worm, it would be a complete different podcast. My understanding is in many European countries, the lines are not well defined. In the UK, it's much more specialized. In the training program in general surgery, within general surgery, there's transplant, HPB, the vascular just split out. Breast surgery still count under general surgery. Esophagogastric, HPB is general surgery. So it is very relevant to just the training pathway and how we specialize later on in a training pathway that define who we are. And in fact, it is then in this sense, we're defined by, we call the fellowship exam, the last exam, FRCS. There are different themes to our exam. So you could be a general surgeon with the FRCS in upper GI or lower GI or HPB.
Okay.
But it's
So
very
do you ever do general surgery and then just specialize again in general surgery, or you have to branch out into one of those three?
we have to branch out in so
Ah,
we choose when we choose general surgery, then we in our training we have to branch out in one of the many, including transplant, upper GI, lower GI, and then but we still all do general surgical on call. So everyone still does the general surgical on call, but then in our elective work is different.
Another question I have for you, though, and I hate to focus on this, but I'm too curious. Imperial College, that is a very strong name, right? So what does that mean? Um, does it mean empire? Does it mean that the royal family is involved with that? It never occurred to me what a provocative name that is until now.
Well, first I must bring the clear the cloud first. Imperial College Healthcare NHS Trust is a completely different entity to Imperial College London. So you have a university, that's Imperial College London. You have in the hospital, that's NHS run as a healthcare system within NHS. And yes, they are overlinked. Yes, most of the surgeons or academics that they will work within the Imperial Healthcare Trust, but you kind of have to see them in a different entity. Imperial College, essentially, the history, I can go long back, but it's just a name of the college. And I must promote other colleges or other universities within London, the King's College, the UCLH, St. George's, it belongs to, I think, they have their or medical school. So within London, there are many really renowned, good medical schools, and then and they all come together. So I graduated from Bristol University, I must say. Then I did my PhD at Imperial. So I'm very neutral. I'm proud to be Imperial, but I'm not, arrogant to be Imperial.
So you're remind me where you're born, or where your origins are from. I mean, I know, but I want the listeners to hear.
Yeah, absolutely. I am originally from Taiwan. I came to England to do what we call A-level, which is high school.
Were you like 2 years old when you moved to England? Because you speak English with the Queen's English better than I speak English.
I used to have a really strong American accent.
Oh no! What happened?
I came to England when I was 15, 16.
Okay.
With my sister. My parents are still back in Taiwan. I grew up, my mother tongue is Mandarin. I grew up in a very kind of Chinese Mandarin speaking Taiwanese, system, but I wanted to go and see the world. So I think I was high school, senior high school, that's how we count in Taiwan, year 1. And then I wanted to study abroad.
Interesting. And actually, just another question. What Chinese is spoken in Taiwan? Only Mandarin?
We have the dialogue of Taiwanese, and there's Hakka, but Mandarin is the official language.
Okay. And so no, just I'm just trying to think. I'm gonna stop talking about the empire, I promise. So we met Alice in Portugal a couple of weeks ago for a meeting, and EAES meeting actually.
Yeah.
And you were kind enough to host me on a podcast. I had a wonderful time. Tell us a little bit before we get into kind of your side gig on quality assurance. Tell us a little bit about the EAES, how you work with them, and how you started doing the podcast, and a little bit about social media and surgical societies, if you would.
It's a very interesting story. So EAES, I would say, is one of the biggest European societies. It's also got a really good relationship with SAGES. My involvement with EAES actually began with 4 or 5 years ago, that I got selected to be within the Education and Training Committee. So I stayed in the committee for about 4 years. So attending all the meetings and all the committee meetings and driving the education and kind of fellowship programs and within the EAES. And then my term comes to a stop. And by rules, I can't be re-elected for another 2 years before voting back in. But in one of the talk I gave in the winter meeting, funny enough, I think it's 2 years ago, the presentation I gave, the technology didn't work on the screen. So it was I did a really beautiful presentation on coaching, because I really wanted to promote surgical coaching and how that can promote improve surgical techniques and cutting down the learning curve. But I was devastated. Then the podcast company approached me on that day. So the EAES brought the podcast in and said to me, Alice, why don't you give us an interview on the thing you just said? And I said, thank you so much. Let's have an interview, have a chat about it. So afterwards, this was broadcasted, and I realized instead of having, so that winter meeting, maybe a few hundred people, 200 or 300 people in there, you know, just like the one we went to. Winter meeting is a small meeting, it's not a lot of people attending.
Yeah.
Instead of getting frustrated by these live conferences, get, you know, angry about the presentation not reaching out to this just 100 people, podcasts can deliver messages across the world. So then I got really excited and I said, yeah, yes, if you want me to help you with this, I would love to. And then somehow I got roped in. Then I got roped in. I had no choice. I didn't choose you. You got chosen.
I know.
By EAES.
I know.
But now here we got an amazing relationship through this.
So I love what you say, because, you know, Vincent and I are certainly from a different generation than you. We'll put it that way. And for many, many years, I thought best way to teach was to go to class and in you know, in person, what have you. And when all this online teaching came along, I was very resistant. But ultimately, I gave in. I did an integrative medicine fellowship at the University of Arizona, where the majority of it is online. I ended up doing even like a master's. I ended up even doing an MBA online. And by far, the best way to learn is actually when you're mentally ready to get the information, or if you don't hear something, you can record it. So it's a perfect example of how technology actually is a fantastic way to disseminate and to teach people. So I never really thought about that with our podcast or what have you, but it's a good point. We kind of need to promote it a little bit more, Vincent. Actually, Vincent and Alice, talk amongst yourself. Someone's trying to deliver me something, so I apologize.
What do you think, Vincent? Is that what how you why did you go?
I mean, I did my MBA in finance that was online at UMass Amherst here in US. I did a master's in information system that was hybrid. Half of it was face-to-face in the room with people, and half of it was online, so that was blended. I do agree with Andrew that there's tremendous value in being able to engage online, but I do like the face-to-face collaborative brainstorming, working on a whiteboard that comes with face-to-face. So, you know, the blending is probably the best if you can blend it, but without that, look what online education has done. It's helped people around the world get access to education that they couldn't get. They live in some small village in a small town somewhere. They can go online and take classes online at Cambridge or Oxford or Harvard or anywhere else. So that's, you know, it's amazing.
So we're already through the halfway mark. So Alice, tell us a little bit more about quality assurance.
Sure.
You sound like, yeah.
So
and then we're going to talk a little bit later about how maybe different ways of communicating, you know, like we're doing now, is maybe a good way to do quality assurance. And we'll see if we see if any AI applications could help with that.
So I began my journey of surgical quality assurance in 2009, 15, maybe 2015, nearly 10 years ago, and where I walked into this PhD project, and my task was surrounded on the Color 3 trial. So the Color 3 trial is the laparoscopic versus transanal total mesorectal excision, following by the success that the VU Medical Center did for Color 1, the original Color trial, and Color 2 trial, and the Color 3 trial is comparing these two. But the difficulty they had was transanal TME at the time is a very novel, innovative technique. So the question is, how do we compare the two procedures, whilst one of them is still within its learning curve, not only the learning curve of the surgeons, but also technology itself. So the task was to come up with a plan to standardize the technique, to assess the competency of surgeons, and have a trial entry and monitoring process within this trial. And just put perspective in this trial was setting a sample size of more than 1,000. It was across 3 continents. And they had multiple, you can see how many surgeons from each country participating in order to reach the goal. So that was the task we were given. So so going from there, we developed a standardization of the technique through Delphi consensus, going through to develop a competency assessment tool. This is based upon the track record that Imperial College had. My supervisor, mentor, Professor George Hanna. And then actually apply this into a trial situation. And what we found was through our experience that we were able to standardize by knowing within one operation which one within the trial condition, what is mandatory, optional, and prohibited steps, and recording that within both operation notes, but also everyone has to submit the videos and upload that into, I think Vincent would like this part, developing an online platform to be able to upload, to anonymously score these.
And also all that video data. That's so great so you can do surgeomics on that video data. That's fantastic. Was it the whole procedure that had to get uploaded?
Yeah.
Or
Yes, it's the whole procedure. So you can imagine 10 years ago, it was, so my last chapter of my thesis was on barriers to implementation. 10 years ago, it was really super hard. The exchange of videos was on hard drive.
It's still hard. It's still hard. Yeah, definitely. But back 10 years ago, forget it. Yeah, I can only imagine. 1,000 videos?
Well, so the arrangement of this was Imperial College was in charge of the methodology of the quality assurance, and the VU Medical Center was in charge of the actual the trial running. So the video collecting, and then we give that part to them, and we develop the methodology of how to do quality assurance. But in the days we basically exchange these videos on hard drives and things when we meet each other in conferences.
Yeah.
And then the second task, and we're talking about what AI can do today, it was impossible to watch every single video and use a competency assessment tool
and
to
maintain your sanity. Yeah.
Because so that we kind of went down to the protocol went down to we'll watch 1 out of every 3 videos.
Yeah.
Because it's just not possible. Not only because
without AI, it's not possible.
Without AI, it's not possible.
Yeah.
But the time has changed.
Yeah.
So now the possible, I believe in the next few years will become the impossible will become the possible. Many groups in the world is working on it now.
That brings up such an interesting point, because I always remember there's a thoracic surgeon had a that I know had a patient that bled, and they had the video, right? They had the video, and what happened was there was like a ligature, and for whatever it was during an esophagectomy, and the ligature was there, whatever, and then they took off the ligature, and a pulmonary artery was cut, massive bleeding, blood everywhere. So you look at that video and okay, I won't even say what my opinion was, but the lawyer said, I can defend that. Like, oh, I can, and which was kind of blew my mind. I have to be honest, but wouldn't it be interesting if we actually had access to massive amounts of data, and we actually had a way to kind of analyze videos objectively, because we don't have that at all. It's kind of insane if you think about it. How many, like the field of like airline pilots, they must have tons and tons of data that's analyzed, and we surgeons in the operating room, we still do not analyze. Even athletes review their video data more than we do, and it's really kind of insane.
Yeah,
it's insane.
Yeah, I think the first is to look at what is our motive of looking at these videos. And I think one thing that the reason that the Western world, or at least the surgeons I know in England or many people in Europe, are quite against videos recording is because they feel it's a judgment. And it is.
Thank you. That was exactly it. The fact that they had the video even though there's blood everywhere. But the surgeon was just operating normally, calmly. And from a layman's point of view, the lawyer was like, "Oh, I get that. That's easy to show to the jury that nothing negligent was happened." And surgeons
Right.
don't get that
Right.
because even me, I'm
Right.
telling you the story, and even when I'm telling you
Yeah.
the story,
Yeah.
I still made the same mistake. Like, oh, there's blood everywhere. They're not going to like it, and it's not the case. And surgeons need to change their mentality.
No, absolutely. I think it is changing though, the culture is to become more transparent, that we're learning. We're talking about a drastic mistake here being the pulmonary artery or vein being cut, but that would be, there's so many external factors leading to that. And then learning from small mistakes into bigger mistakes, using the videos and, laparoscopic where we're doing now, this is completely transforming what we understand about during surgery. The other thing I want to touch upon is again emphasizing how important these podcasts is that different part of the world behaves differently. So in Asia, where I'm from in Taiwan, because I spent 10 months as a post CCT fellow in Taiwan, they the institute that I went to, they record every single video. It's a culture. It is within the ingrained. So there's a cupboard inside, there's lots of drives, and there's surgeons name, the nurse go and take it and put it on. It is just part of the culture.
Yeah.
So you're talking about, oh, we don't have access to this. I think it needs to be a collaborative work internationally. I do know from being Taiwanese myself that there are weaknesses in our methodology developing in technology in Taiwan, that we're not strong, but we are very strong in collecting data, patients, our hardware, the chips. I have to mention the chips. Whereas the Western world, the British, the American, are really creative, developing. If everybody come together and
Yeah.
share,
Yeah. Yeah.
we can solve this problem really quickly.
Yeah, no, absolutely. Yeah, that's the $1 million question right now. But again, I will resist continuing on this topic. So now, Vincent. So Vincent, you're hearing a lot about video data, quality assurance. Obviously, they have programs now that do autonomous annotation, so we can look at it. But specific, so we can analyze, anatomical structures and have some guidance. But in quality assurance, how can we get there to the point where every video is recorded, to the point where every video is analyzed, to the point where if you're in the operating room and a resident and someone has bleeding, that automatically other people are called to come in and help, and all these simple things that should exist by now, but do not because of the culture that surgeons have created in most parts of the world of of blame, of morbidity and mortality, of this kind of malignant way of analyzing complications, this trauma that is constantly shoved down throat a surgeon's throat, and we're almost like, I remember in America we were almost like beaten children that would then beat their children. How do we break the cycle? How can AI help us?
Yeah, that's a good question. I mean, we, as you remember, we have a paper in our journal on recording in the OR, and the technical challenges are not the problem, right? The computer vision is very good, and you can train your model, and you can annotate videos, and it's really just boils down to the medical legal consequences of what's discoverable in a lawsuit, and that's the big block for getting it to be routine, protected, controlled, standardized, peer reviewed, which is what we all want. We all understand that. But at least in the US, the legal folks have enormous amounts of influence. And when something becomes discoverable, the same thing can be looked at five different ways in front of a jury. And
Mm.
they don't understand it. They know what they're being told or explained. So that's part of the challenge. It's really not technical anymore. It was technical, but now it's just purely bureaucratic, legal, med legal. It's very sad, but we've made a lot of progress. So it's
Yeah.
slowly moving forward. So that's good news.
It kind of reminds me of the culture of silence around what's happening with um, around Epstein, right? Things were being done for decades, things that, very questionable things are done, and there's this element of secrecy where people won't talk about it and won't reveal what's really happening. And I have to say, there's a parallel. I hate this is prime guy. Luckily, this is our last podcast for the day because I'm a little bit maybe too polemic today, but there is a parallel of this culture of silence, and hopefully we can change it because there's so much data out there that we've all been alluding to. So what other things we're definitely getting towards the end of the podcast, but what other things are you looking at when you do QA at your institution? Are you looking at self-reporting? Are you looking at like a situation awareness tools in the operating room, maybe that again, like I said, can alert maybe the head of surgery that one of their younger surgeons is having a problem in the operating room, or vice versa, that one of the older surgeons is having a problem. Do you have
Yeah.
any alarm systems like that, or any plans for it, or
Um, so the quick answer is no, and the long answer is within Imperial College, there's many research groups looking into different side of things. So, the touch surgery that was not being acquired by Medtronic was started off by at Imperial, and they are very much on surgical education and video recording. And there's another engineering group looks at the data you can get from the sensors on surgeons and how decision making and cognitive load. Um, my particular area and our group is looking at quality assurance within the trials setting. The clinical trial is very different to the day-to-day work, but also in particular, I am very interested in how do you improve from novice to competent, and what makes an expert surgeon. And then
you,
so
you know
yeah,
what, Alice? I'm gonna jump in here in the interest of time because I want to like refine my question to you because as you were talking, you made me think of something.
yeah,
What about, and it's what we were referring to earlier, what about the trauma that the surgeon
yeah,
gets when they have a complication, when they have to go through quality review?
yeah,
What about burnout? There's a lot of ways AI could help with that also, right? You could have sensors on the surgeon to look at their vital signs during a surgery. An alarm could go off, to someone like, hey, the surgeon's heart rate is 160. Maybe something's happening or about to happen. Maybe I should check in on them. But even, access to therapists or after a bad event, is there
uh,
anything being done by that, done within the QA department? Because I think I don't know if I was talking about it with you, but I was at a conference and we were talking about, I personally know four surgeons who committed suicide, like that, four
uh,
people that I've met. And
yeah,
so I want to end
got
with this. So good luck with
yeah.
with answering with solving that
Yeah.
problem.
You that so the no is the answer, but yes, we should is the second, and the
Yeah.
leading on is in the end of the day, quality assurance is to improve, right? It's not just to say it is not to just to say this is good or bad. It is to change. And not only changing for the quality, but also changing for the surgeons and how we look after ourselves and our colleagues. So you're absolutely right. And that's what I like to lead into. I believe the next wave of using education, which is actually my main interest into quality assurance, is surgical coaching, is, the
Hmm.
all the really esteemed um now though I in England, the big thing right now is the Six Nations rugby. So the great athletes, the Winter Olympics, they have coaches.
Yeah.
Why, and how do we look after that, and how do we then um safeguard these really true burnout and then really sad stories, and but absolutely.
Well, that's fascinating. I love that you brought up the Six Nations because
France, France
France.
yesterday.
I'm in France, so you can imagine, my a good friend of mine's Irish, so I don't want to comment more on that. But did Italy really beat Scotland today? Did that actually happen, or did I
I
read that
didn't watch
correctly?
that. England is playing with Wales right now, so
Yeah,
much more
someone sent me a
important.
text, but I think I read it wrong. But maybe I didn't. But it's a beautiful point you make. Is like, why don't surgeons have coaches? And more importantly, why don't older surgeons act more like coaches? I had
Mm,
some great mentors who that's exactly what they were, unpaid coaches, but they act as my coaches. But then you see, some people who are in positions of power who
mm,
are quite the opposite of a coach.
mm.
They are what is the opposite of a coach? I can't say it. I don't want to say it because
A referee.
No, no, I want to use
Yeah, a different.
a naughty word to describe them. But unfortunately, that exists. But it would be beautiful if we could incorporate somehow a coach, maybe even an AI coach, Vincent,
Mm,
maybe with generative AI. Maybe you could put in your complication and it could kind of talk to you about it, or something like that. That would be actually interesting because a lot of people, I think, would have a hard time. We find this with patients. A lot of humans have a hard time opening up to another human, but maybe opening up to an AI that could talk you through it would be an easier way for some people to kind of process
mm,
um, bad outcomes. What do you
yeah.
think, Vincent?
Yeah, I mean, I think anything could be helpful for transparency and getting surgeons to open up. And again, if they can open up knowing that what they're saying and discussing is beyond discovery, just like morbidity and mortality conferences, that information is not discoverable.
In
Mm.
So,
America, what
yeah,
about what about in England, Alice? Can
So
you just
yeah,
the
the
M&M
mortality.
conference? So
Yeah.
that in America, apparently it's protected,
yeah.
but in England, is
Oh
it
no,
also
it's very
protected?
transparent. No.
Wow.
Yeah,
Yeah.
yeah. So,
Yes.
one of the things I love about being in Europe is it's a real, in the public sector where I work, is Imperial a public sector?
Public. Yes. Yeah.
Yeah. So it's a team.
Yeah.
And working for a team is so much better for a surgeon for multiple reasons, except economically. Okay. The benefit of private practice is an economic advantage, but
Sure.
then you're on your own and there's no team. And I
Is
will,
that across all US? Sorry, forgive my naivety. Is that just the standard in US where everyone just
there's not the same team mentality as there is that, I've operated in many parts of the world, and there's much more of a team mentality in Europe,
yeah.
let's say, than in the Americas, in North and South Americas, from what I can tell. And that's one of the problems with possibly, well, there are multiple problems, reasons for that, but we don't really have time to go into that. But the team mentality is much better and much better for the soul.
Mm, great.
So, oh God, there's one other thing I wanted to talk about that, but I cannot for the life of me remember, and the clock is ticking. But Alice, thank you for a very thought-provoking, podcast. I think, Vincent, we should think about creating somehow an AI-powered coach for surgeons,
Sure.
maybe with Alice. I think that would be, maybe the EAES can help us with that, Alice. But I think that would be relatively easy to do, you know?
Yeah.
And I think maybe if you could see a surgeon going down a dark hole, maybe the AI coach could help, alert someone, a therapist or what have you. It'd be relatively easy to do. But we're out of time. So Vincent, please close us out before our
Okay. So
thing
we're
shuts.
at episode 79. Thank you, Alice, for joining.
Yeah,
Uh,
yeah.
we're done,
Thanks.
right?
Thanks a lot, Alice.
Thanks,
We'll we'll
Alice.
we'll, we'll see you. Have a good
Thank
rest
you
of
so
your day.
much.